Let us see how nerve supply to the upper limb goes, and let us also examine the features of nerve injury of the upper limb. Brachial plexus is formed by ventral rami only. These are of which spinal nerves? Answer C5 to T1. So brachial plexus is formed by the ventral rami only of C5 to T1 spinal nerves. Brachial plexus nerves may be divided into those containing anterior division fibers which supply flexors and posterior division fibers which supply extensors. Which nerves contain which? Anterior division fibers are contained in musculocutaneous nerve, median nerve, and ulnar nerve. Posterior division fibers are contained in axillary nerve and radial nerve. So, brachial plexus nerves which supply the anterior part of the upper limb are musculocutaneous nerve which mainly supplies the arm, median nerve which mainly supplies the forearm, and ulnar nerve which mainly supplies the hand. And posterior division fibers are these fibers which innervate the muscle of the back of the hand. These are axillary nerve which are contained in axillary nerve and radial nerve. Divisions of brachial plexus are confusing. Commonly, students remember this as TDC. What does this stand for? Trunk division cord. Now, as we know, brachial plexus begins from the ventral rami of spinal root C5 to T1. From these roots, the superior, middle, and inferior trunks are formed, and C5 C6 goes to the superior trunk, C7 as the middle trunk, and C8 T1 as the inferior trunk. Now each trunk divides into anterior and posterior divisions. From these divisions, the cords are formed. From the anterior divisions, the lateral cord and the medial cord are formed, while the posterior cord is formed from the posterior divisions. Let us see how the trunks are formed. The trunks are formed from the ventral rami of the spinal root C5 to T1. C5 and C6 join to form the superior trunk. C7 continues as the middle trunk, while C8 and T1 join to form the inferior trunk. Now let us see how the cords are formed. The lateral and medial cords are formed from the anterior divisions, while the posterior cord is formed from the posterior divisions. So posterior cord is formed from the posterior divisions of all the three trunks, while the lateral cord is formed by anterior divisions of the superior and middle trunk, while medial cord is a continuation of the anterior division of the inferior trunk. Let us simplify this by telling that posterior cord is formed from posterior divisions, while lateral and medial cord are formed from anterior divisions. Now, which nerves arise from the cords? From the lateral cord, the musculocutaneous nerve comes. The lateral and medial cords both contribute to the median nerve. And from the medial cord alone, the ulnar nerve comes. So ulnar nerve is from the medial cord alone, median nerve is both from lateral and medial cords, while musculocutaneous nerve is from the lateral cord. So these are the anterior nerves. Now posteriorly, the posterior cord first gives a small axillary nerve, and then it continues as the radial nerve. So these are the 5 main nerves of the brachial plexus: musculocutaneous nerve, median nerve, ulnar nerve, axillary nerve, and radial nerve. Now, what are the segmental supplies of the various nerves of the brachial plexus? As one can very well imagine, the median nerve gets supply from all the anterior divisions. So, same way, the radial nerve also gets supply from all the posterior divisions. So, median nerve and radial nerve have C1 to C5 to T1 segmental supply. That is, all the segments contributing to the brachial plexus will contribute to median nerve and radial nerve. Now, musculocutaneous nerve, which is on the upper side, just like the axillary nerve, which is on the upper side, these two have segmental supply of C5, C6. The ulnar nerve, which is on the lower side, has supply from C8, T1. So, musculocutaneous nerve C5, C6, median nerve, all the segments, that is C5 to T1, ulnar nerve C8, T1, axillary nerve C5, C6, and radial nerve, all the segments, that is C5 to T1. Musculocutaneous nerve, muscles supplied and actions of these muscles. Now, among the 3 anterior compartment nerves, that is musculocutaneous, median, and ulnar. Musculocutaneous nerve supplies the arm, median nerve supplies the forearm, and ulnar nerve supplies the hand. So, musculocutaneous nerve supplies the anterior compartment of the arm. This is responsible for mainly flexion of the elbow and also for supination by innervation of the biceps brachii. Now, for supination, the radial nerve also contributes, because radial nerve innervates the supinator, which helps in supination. So, supination is by the action of both musculocutaneous nerve and the radial nerve. Musculocutaneous nerve via innervation of biceps brachii, and radial nerve via innervation of supinator. While pronation is exclusively an effect of muscle supplied by the median nerve. Median nerve, muscle supplied and actions of these muscles. Median nerve is a nerve supplying mainly the forearm muscles of anterior compartment of forearm. And just like musculocutaneous nerve is for the arm and ulnar nerve is for the hand. Now, for the forearm muscles, there is a small contribution from the ulnar nerve also, but mainly the anterior compartment is all supplied by the median nerve. Actually, in the forearm, the flexor carpi ulnaris and the ulnar head or the ulnar part of the flexor digitorum profundus are supplied by the ulnar nerve, while all other forearm muscles are supplied by the median nerve. Median nerve also supplies some muscles in the hand, which are best remembered by the mnemonic meatloaf. That is, median nerve innervates loaf, L for lateral two lumbricals, then O for opponens pollicis, A for abductor pollicis brevis, and F for flexor pollicis brevis. Note that opposition of the thumb is by the opponens pollicis, abduction by abductor pollicis brevis and abductor pollicis longus, which is a muscle of the forearm, and flexion of the thumb by flexor pollicis brevis of the hand and flexor pollicis longus of the forearm. Now let us see the actions of the muscles innervated by the median nerve. In the forearm, median nerve innervated muscles produce pronation, produce flexion of the wrist, and flexion of the digits 1 to 3. What about in the hand? In the hand, we always think in the order thumb, lumbricals, inrosi. Now, thumb opposition is by the opponent's pollicis. Thumb flexion is by both flexor pollicis brevis of hand and flexor pollicis longus from the forearm. Thumb abduction is by both abductor pollicis brevis of the hand and abductor pollicis longus of the forearm. Now, the importance is that if there is a lesion of the median nerve at the elbow level, then in the thumb, opposition, flexion, and abduction are gone. While if there is a lesion of the median nerve at the wrist level, then in the thumb, opposition is gone, while flexion and abduction are preserved. Now, median nerve also supplies the lumbricals, the lateral two lumbricals, which act on digits 2 and 3. And what is the action of lumbricals? Lumbrical action everywhere is MCP flexion or metacarpophalangeal joint flexion and extension of the interphalangeal joints, that is DIP and PIP extension. Ulnar nerve, muscle supplied and actions of these muscles. Now, as we know, ulnar nerve is mainly a muscle of the hand. It has some little supply in the forearm, but mainly it is a muscle of the hand. Now, in the forearm, ulnar nerve innervates the flexor carpi ulnaris and the ulnar portion of the flexor digitorum profundus. In the hand, we go from thumb to lumbricals to the inrosi. So, in the thumb, the ulnar nerve supplies the adductor pollicis alone. Note that abductor pollicis brevis, flexor pollicis brevis, and opponent's pollicis are supplied by the median nerve. Then, ulnar nerve supplies the medial two lumbricals. That is the lumbricals going to the 4th and 5th fingers. Then, ulnar nerve supplies all the inrosi, that is all the dorsal and palmar inrosi. Now, let us see the actions of the ulnar nerve. Ulnar nerve is due to its innervation of muscles of the forearm. It produces weak wrist flexion and also flexion of digits 4 and 5. In the hand, we always go in the order of thumb, lumbricals, inrosi. For the thumb, it innervates adductor pollicis, so it produces thumb adduction. Now, it innervates the medial two lumbricals, so it is responsible for the lumbrical actions on digits 4 and 5, that is flexion of the metacarpophalangeal joints and extension of the both proximal and distal interphalangeal joints. Now, ulnar nerve innervates the inrosi, and the inrosi actions are remembered by the mnemonic DAB pad, that is dorsal abduct and palmar adduct. So it produces abduction and adduction of the fingers 2 to 4. Axillary nerve, muscle supplied and actions of these muscles. The axillary nerve supplies the muscles deltoid, which is the major muscle, and also a small muscle called teres minor. The action of the deltoid is abduction of the shoulder in the range of 15 to 110 degree, and because Another effect of the axillary innervated muscles is lateral rotation of the shoulder. This is a minor action by its innervation of the teres minor muscle. Now about abduction of the shoulder, 0 to 15 degree is by the supraspinatus, 15 to 110 degree is by axillary nerve, and rest of the abduction is actually due to rotation of the scapula. Radial nerve, muscle supplied and actions of these muscles. Radial nerve mainly innervates the posterior compartment of arm and forearm. There is no muscular innervation of the radial nerve to any hand muscle. It also innervates the supinator. So radial nerve produces extension of the elbow, wrist and fingers, and also supination. Note that supination is also an effect of biceps brachii muscle supplied by the musculocutaneous nerve. Which are the collateral nerves of the brachial plexus? The collateral nerves are the nerves which arise directly from the brachial plexus, other than the 5 major nerves which I told, which are divisions of the cords. Now, one nerve is long thoracic nerve, which supplies the serratus anterior, and serratus anterior is the muscle responsible for protraction and superior rotation of the scapula. Another nerve is the dorsal scapular nerve, which supplies the rhomboids. Another nerve is the suprascapular nerve, which supplies the supraspinatus and the infraspinatus. Supraspinatus is responsible for shoulder adduction from 0 degree to 15 degree, while infraspinatus produces lateral rotation of the shoulder. Subscapular nerves are upper, middle and inferior. Upper one supplies subscapularis. Middle one goes to the latissimus dorsi and is also called thoracodorsal nerve. Lower one innervates the subscapularis and teres major. Pectoral nerves are medial and lateral. Medial pectoral nerve goes to teres major, pectoralis major and pectoralis minor, while lateral pectoral nerve goes to pectoralis major alone. Medial cutaneous nerves are brachial and antebrachial, which go to the skin of the arm and the forearm. What is the segmental innervation of upper limb motor supply? It is quite easy to remember. When we go up from the shoulder joint to the tip of the fingers, that is when we go down from the shoulder joint to the tip of the fingers, the values increase. So at the shoulder joint it is C5, C6. At the distal arm and proximal forearm it is C6, C7. In the distal forearm it is C7, C8, and in the hand it is C8, T1. This has importance especially when some spinal roots are affected, like in disc herniation, or if the trunks of the brachial plexus are affected, like in Erb's palsy or Klumpke's paralysis. What is the sensory innervation of the hand? Ulnar nerve innervates the medial 1.5 fingers, both on the front side and the back side. Rest of the anterior surface is innervated by the median nerve, while rest of the posterior surface is innervated by the radial nerve. Now about the median nerve, one important point to note is that sensory loss of the hand is not a feature of carpal tunnel syndrome, because the sensory branch of median nerve goes above the carpal tunnel. And one important point about the radial nerve innervation of the posterior hand is that the radial nerve is the nerve which innervates the skin over the anatomical snuff box. What is Erb-Duchenne palsy or Waiter's tip syndrome or upper brachial plexus lesion syndrome? Now, Erb's palsy happens when the upper trunk of the brachial plexus is damaged or C5-C6 is damaged. This affects the suprascapular nerve, axillary nerve, and musculocutaneous nerve. Now, axillary and musculocutaneous you will remember because they are the nerves coming from the upper part of the brachial plexus. Also, the suprascapular nerve. Now, Erb's palsy happens when the head and shoulder are forcibly separated, like during birth injury, accidents, or disc herniation. Usually, this happens in birth injury. Now, here what happens? The arm is adducted and medially rotated because of loss of suprascapular nerve and axillary nerve. The forearm is extended and pronated due to loss of musculocutaneous nerve. This produces the waiter's tip position. There is sensory loss in the lateral forearm, which is usually innervated by the musculocutaneous nerve. What is Klumpke's paralysis or lower brachial plexus lesion syndrome? Now, Klumpke's paralysis is due to affection of the lower trunk of the brachial plexus, that is C8 and T1 are damaged. The cause is forceful abduction of the shoulder, like when grabbing an object while falling. It can happen during birth injury, and it can also happen in thoracic outlet syndrome. Now, C8T1 supplies the intrinsic muscles of the hand. So, intrinsic muscles of the hand are gone. So, classically, there is claw hand of all the fingers. So, claw hand of all the fingers happens in Klumpke's paralysis. We know that claw hand of the fourth and fifth fingers alone happens in ulnar nerve lesion, while claw hand of second and third fingers happens in median nerve lesion. One important feature of Klumpke's paralysis is that there may be associated Horner syndrome due to affection of sympathetics. In Klumpke's paralysis, there may be sensory loss of the medial forearm and the medial 1.5 fingers. We know that in Erb's paralysis, there may be sensory loss in the lateral forearm. So in Klumpke's paralysis, there is sensory loss of medial forearm. What is the segmental innervation of skin of the upper limb? So here we have to go from the outer surface down and then through the inner surface up. So C5 is to the lateral arm, C6 is to the lateral forearm, C8 is to the medial forearm, and T1 is to the medial arm. Features of radial nerve. Radial nerve supplies the muscles of the posterior compartment. So the main feature is loss of extension of elbow joint, wrist joint, and fingers. The classic sign is wrist drop. Radial nerve also supplies the supinator muscle. So radial nerve injury produces some weakness of supination, but supination is also provided by biceps brachii innervated by the musculocutaneous nerve. In radial nerve injury, there is sensory loss of posterior arm, posterior forearm, and posterior aspect of the hand, excluding the medial to 1.5 fingers supplied by the ulnar nerve. Sites of injury. In the axilla, radial nerve may be injured by improper crutch usage, Saturday night palsy, and by inferior dislocation of the shoulder. In inferior dislocation of the shoulder, radial nerve injury comes along with axillary nerve injury. Radial nerve may be affected in the radial groove of mid-humerus, in lateral epicondyle fracture, and in radial head dislocations. In injuries at these sites, elbow extension is not affected. In wrist laceration of the dorsum of the wrist, the superficial branch of radial nerve is affected, leading to sensory loss of the hand in the posterior part, but there is no motor loss. Median nerve lesion features. Now, median nerve is primarily a nerve of the forearm. It also gives innervation to the thenar muscles and the first two lumbricals or the lateral two lumbricals. And it gives sensation to the palmar area of the hand, excluding the ulnar 1.5. So with this idea in mind, we will see how a lesion in medial nerve will manifest. Now, first about forearm muscles. Now, as we know, median nerve innervates muscles which produce pronation and wrist flexion. So there is loss of pronation. In fact, there is no other nerve which is supplying pronators. So there is a loss of pronation. Now there is a weakness of wrist flexion. There is no total loss of wrist flexion. This is because wrist is also flexed by muscles innervated by the ulnar nerve. That is, in fact, flexor carpi ulnaris and ulnar part of flexor digitorum profundus are supplied by the ulnar nerve. So wrist flexion is weak and not impossible, and because of action of ulnar nerve there will be an ulnar deviation. There will be an ulnar deviation during wrist flexion. Now, in addition, the ulnar nerve supplies flexors going to the first three fingers, that is thumb and the next two fingers. So when we attempt to make a fist, the fourth and fifth finger will be able to flex while the other three fingers cannot, producing what is called hand of benediction. So note that hand of benediction is an active sign, unlike claw hand, which is a passive sign. So that is about forearm muscles. Now what about the hand muscles? As we know, the median nerve supplies, we know the mnemonic meatloaf. It supplies LOAF, that is the lateral two lumbricals and opponens pollicis, then abductor pollicis brevis and flexor pollicis brevis. Now because of loss of opponens pollicis, there is lack of opposition of the thumb, and this leads the thumb to be in the same plane as the rest of the hand, producing what is called ape thumb or simian thumb. Now what about thumb flexion and thumb abduction? Now here one important thing we have to understand is that flexor pollicis longus comes from the forearm, while flexor pollicis brevis is in the hand. So if the median nerve is affected at the wrist, then flexor pollicis longus will be unaffected, and so thumb flexion will be normal. While if the median nerve is affected at the elbow, then both flexor pollicis longus and flexor pollicis brevis are gone, and so there is loss of thumb flexion. The same goes with abduction. Abduction of the thumb is by abductor pollicis brevis in the hand and abductor pollicis longus in the forearm. So when there is a lesion of the median nerve at the elbow, both these muscles are affected, and so there is loss of abduction of the thumb. While if there is a lesion of the median nerve at the wrist, then abductor pollicis brevis alone is affected. Abductor pollicis longus is not affected, and as a result, thumb abduction will be normal. So that is about the thumb muscles. And also because of loss of all these thenar muscles, there will be a flattening of thenar eminence when the median nerve is a is chronically lost. It's a chronic denervation like in carpal tunnel syndrome. Now about the first two lumbricals or the lateral two lumbricals, these are also lost, and as a result the normal action of the lumbrical is MCP flexion and the interphalangeal joint extension. So now because the lateral two lumbricals are gone, the second and third digits will have MCP extension and interphalangeal joint flexion, producing claw hand. Note that claw hand is a passive sign seen in a long-standing lesion, unlike the hand of benediction, which is an active sign. Next, about sensory loss. As we know, the median nerve supplies the entire palmar surface, excluding the medial 1.5, which is supplied by the ulnar nerve. So we have sensory loss of the palmar surface. Now the sites of median nerve damage. One common condition is supracondylar fracture of the humerus. Usually this happens when there is a fall on outstretched hand, and the displaced fracture will damage the median nerve. So here all the signs will be present, and note that in the thumb, in addition to loss of opposition, there will be loss of flexion and abduction also. Now the commonest site of injury of median nerve is in the wrist, and usually this happens due to carpal tunnel syndrome. Sometimes it can also happen when there is a ventral wrist laceration proximal to the carpal tunnel. Now when the median nerve is injured at the wrist, we have to understand that pronation will be normal, wrist flexion is normal, and there is no hand of benediction. And what will be present? Eighth thumb will be present, claw hand of digits 2 and 3 will be present, and flattening of thenar eminence will be present. Also note that there is preservation of thumb flexion and thumb abduction, because abductor pollicis longus and flexor pollicis longus are spared, because these are forearm muscles, and this will not be affected if the median nerve is injured at the wrist. Ulnar nerve lesion features. Ulnar nerve is primarily a nerve of the hand, but it gives some supply to the forearm also. First, let us focus on the forearm. Now, because of affection of the forearm flexors, that is the flexor carpi ulnaris and the ulnar part of the flexor digitorum profundus, there will be mild weakness of wrist flexion, and when the wrist is flexed, there will be a radial deviation. In fact, radial deviation during wrist flexion means ulnar nerve affected, and ulnar deviation during wrist flexion means radial nerve affection. There will be weakness of flexion of digits 4 and 5, which are supplied by the flexors I mentioned. Now about the hand. Ulnar nerve is the major supply to the muscles of the hand, and we will go in the usual way of thumb, lumbricals and the interossei. Now in the thumb, the ulnar nerve supplies only the adductor pollicis, and so When the ulnar nerve is affected, there is loss of adduction of the thumb. Now about the lumbricals, the ulnar nerve supplies the third and fourth lumbricals, which are going to the fourth and fifth digits. So there will be claw hand of the fourth and fifth digits. Always remember, claw hand is a passive sign, and claw hand of ulnar nerve lesion should not be confused with the sign of benediction of median nerve lesion, because both look similar. But sign of benediction in a medial nerve lesion at the elbow or a high median nerve lesion, this is an active sign when making a fist, while claw hand of fourth and fifth digits in ulnar nerve lesion, it is a passive sign. Claw hand of all the digits, meaning all the lumbricals are affected. This happens in Klumpke's paralysis, where C8 and T1, which supply all the lumbricals, are affected because of affection of the lower trunk of the brachial plexus. So we have finished thumb and lumbricals. Now we go to the introsi. Ulnar nerve supplies all the introsi. So there is loss of abduction and adduction of digits 2 to 5. And ulnar nerve affection manifests as hypothenar eminence flattening, same way as median nerve injury manifests as thenar eminence flattening. Now in ulnar nerve lesion, the sensory loss is in the medial 1.5 fingers, both front side and back side. Now about the sites of ulnar nerve damage. Ulnar nerve may be damaged at the elbow joint, and this happens especially in medial condyle fracture. It may be damaged at the wrist joint due to a blunt trauma to the heel of the hand. This is especially likely to be damaged in this way because the nerve is superficial here and not in the carpal tunnel. And classically, ulnar nerve damage at the wrist occurs in fracture of the hook of the hamate. So these are the two methods or two common ways by which ulnar nerve is damaged at the wrist. Axillary nerve injury can be caused by fracture of surgical neck of humerus and also by inferior dislocation of the shoulder. The features are due to affection of deltoid, loss of abduction of arm to the horizon, and sensory loss over the deltoid muscle. Musculocutaneous nerve injury will lead to affection of muscles of the anterior compartment of the arm. This leads to loss of forearm flexion. There is weakness of supination because biceps brachii is a supinator. But supination is also provided by the supinator muscle innervated by the radial nerve. So supination is not entirely lost, it is only weak. Musculocutaneous nerve injury leads to sensory loss over the lateral forearm. Long thoracic nerve injury causes are breast surgery and stab wound. Features are those of serratus anterior affection, that is loss of abduction of shoulder above the horizon, and winging of scapula. Suprascapular nerve injury. This leads to affection of supraspinatus muscle and infraspinatus muscle. Supraspinatus muscle affection leads to loss of shoulder abduction between 0 degree and 15 degree. Infraspinatus muscle affection leads to weakness of lateral rotation of the shoulder.